And thank you, Dr. Mahapatra. There are we like to take on the questions now.
There's a question in the chat box for Dr. Rakesh Gupta, and it says, do you see a difference between 3D GLS and 2D GLS?
Yeah, certainly. Thank you. This question has come from my very good friend, Dr. Vinod Vijayan, who is passionate about 3D echocardiography. I was expecting this question from him only because I saw him in the meeting. Well, 3D GLS is very well there. It's still in a research purposes. As far as guideline and practice is concerned, we are very well conversed with two-dimension GLS, and majority of diagnostic, therapeutic, and prognostic papers and reports, they are on 2D GLS. Second important thing is 2D GLS is also number of times very difficult to acquire, especially in people who have got a large heart. So in times we'll see 3-dimension GLS definitely, but at present we rely more on 2-dimension GLS.
Dr. Rakesh, once again, congratulations for a wonderful talk. One is a personal sort of a comment, and then 3 queries from me. Using these cutoffs, I look at anything around 12-13% as when less than that would be a mild one, and anything less than 8 would be quite a severe or high risk patient. So my first question would be, what cutoffs do you use? Because there are no standardized approaches here. So what cutoffs do you use? Second question is, how often should we be using in a follow-up of the patient? And the third question is on LA strain. What is your experience on LA strain?
I'll answer one by one. The first question is GLS. I showed you one tertile, second tertile, and third tertile. That was based on exactly what you said, less than 12 and less than 8. And in between 8 to 12, that was a tertile. We are practically following every subject who are coming to our lab. If they're diabetic, hypertensive, we are following them up with GLS with every report. Second is, whenever we see abnormal GLS, we always report and try to inform a concerned physician, look, this is a GLS. And that's true in my practice also. I'm following these people based on GLS. Third important thing is LA strain. I said very categorically, if you have a patient on dyspnea and exertion where no coronary arteries are involved, second important thing is you find LA which is dilated, and these people, they do not have any resting diastolic heart failure. Either you do a LA strain or you do a passive leg raising test to unearth the evidence of diastolic heart. So we are doing LA strain, especially in those populations where we are expecting a diastolic heart failure, but with reports, we are not able to, with the present guidelines, we are not able to establish the diastolic heart failure.
Thank you, Dr. Rakesh. The other point which you also emphasized, I would like to reiterate the same thing, is that GLS provides incremental information, and especially when we are looking at asymptomatic patients, when we are very early on in the disease, we need to identify at-risk patients at the earliest, and then we should not be too dependent on the LVF. Though LVF is a great tool and still very well established, it's got a lot of data, but increasingly now we find that the GLS is providing incremental information. So especially, I think, I feel that in these mild sort of failures where you have these borderline failures, I think GLS plays a big role. So would you agree on that?
Certainly. I like 2 more points on this. Look, at present, we are on a volcano for heart failure. Everybody would agree to this. Look, the disease, time of coronary artery disease and everything, intervention has gone to a large extent. If we would have taken 20 years down the line, ACS was the most important modality. Today, congestive cardiac failure is the most important modality. When every third patient is a diabetic in our country, virtually, if not third, every 4th patient is a diabetic in our country. In those cases, to decide whether these people have gone to stage B heart failure, this is one modality apart from NT-proBNP, BNP, which helps in delineating to something worse is happening to these people. And we attack those people at a much earlier phase. Possibly we'll save large amount of population not going towards heart failure per se properly. Second thing is, if you have a dilated cardiomyopathy, you must have seen various reports. Somebody read 20%, other person wrote 30%, next person wrote 25%. If we do a GLS in those subset of population, if my previous GLS was 8 and subsequently with treatment has become 12, it means their prognostic value has become better than before.
Thank
So
you,
this
Doctor.
is what clinical implication, which I think, like, we should not, we should not go on based on guidelines, but we should adopt those guidelines in our clinical perspective in our own country. That will be the most useful thing for us.
Very good points. I would now move on to the second speaker, Dr. Elizabeth. It's a question about, especially in the T1 mapping, the ECV. How reliable is it? Is it very robust? And are there any situations where we have where we cannot ask for it? Or are there any challenges in terms of imaging the ECV?
It is quite a robust technique, but things can go wrong if you haven't acquired your images correctly, and if you don't know how to then sort out what to do, you can get wrong values. It is a very good technique. It has its own learning curve, and one also needs to know its limitations. So for example, the native T1, initially people thought it was increased in all areas of fibrosis, but with time, it has been realized that native T1 can just be mildly elevated or can be normal, but the ECV, which is a more sensitive tool, as well as something which does not depend so much on technical factors because it's a ratio, is the way to go forward perhaps. And so I actually showed a case where the native T1 was normal, but the ECV was elevated. So you need to kind of know how to look at these values, how to look at the different parameters. There is a T2 parameter also, which was not in the scope of my talk, and put the things together along with what your basic cardiac images are showing before you come to a conclusion. So that does need some experience, and the best way to acquire it is just keep doing parametric mapping on every patient you have and look at those images and try to make sense out of it based on your basic cardiac MR imaging.
Are there any clinical situations where it may not be sort of indicative to ask for that? Are there any clinical scenarios?
Viability is something where we don't ask for mapping, though there a lot of papers are there on mapping in viability. The way it does take up, every additional sequence takes up additional time on your gantry. So, the more of these things you add on, the more time you will be spending on a cardiac MR image. So the way we have philosophized is viability, whether the T1 or the ECV is elevated, it is not going to change the management of the patient. It is based on the transmurality of the infarct, which is well seen on the LGE. So we don't do it for viability. Whereas it is in the cardiomyopathy where it helps us. And a classic example would be amyloid and Anderson-Fabry disease. Now, in amyloid, the T1 and ECV is grossly elevated. It's not that you can't diagnose amyloid without mapping, but you may be caught in situations where you're not really sure, and it gives you that additional tool. Anderson mapping, the T1 is really low, but the ECV is maintained. But then how many cases of Anderson-Fabry do you really see in daily practice, So, and the range of conditions in between, definitely it helps. It helps in picking up early fibrosis. So that helps in prognosticating and treatment management. So there is a definite role for mapping, but as long as one knows its limitations. For example, it is not the area which shows fibrosis in delayed enhancement that you want to know the mapping of. It will be elevated. It is in the areas which don't show fibrosis, which look black and normal on LGE, that you want to know, is there fibrosis on those areas also? And then if the mapping is elevated there, then you know that the fibrosis is much more than what you are actually picking up on LGE. So it is an additional tool and should be used.
Those are very good messages, Dr. Elizabeth. I now ask my coaches if they have any points, questions.
Dr. Sanjay had a comment and question.
Thank you, Johann. It's been nice to be part of this this group where you have different modalities coming together and discussing heart failure. My question was actually to Dr. Rakesh, because he has done a lot of strain work, and he's obviously does it on echo. And we see other modalities such as CMR talk about spectral tracking and using it to evaluate strain analysis as well. So my question is, what is his take on other modalities coming in and trying to do strain analysis? Has he found them to be as useful? Are the different values that come in when you start using other modalities? And can you do a direct comparison with echo, or can you not do that?
Definitely it takes some time. Look, GLS is established for a long time, more than a decade now. The first paper you can see as early as in 2000. And when this modality was started, now we have to have a head-on trial to talk about these modalities with other imaging modalities. That's one, question number one. Second important thing is the most easily available GLS. Look, you cannot do a PET CT, you cannot do a MRI, and you cannot do other modalities again and again. But this is one which you can do even a bedside. Just go walk in, attach an ECG, acquire a good imaging quality, and that's it, done. So in time, the development which is going to happen more in this 2 dimension, going to 3 dimension, when we talk of a layered specific GLS. That is right now in pipeline. Maybe over a period of next 5 years or 7 years, when we have a better imaging modalities in echocardiography, we may have those kind of a thing when we can really delineate those things. But at present moment, I'll say this is going to play a significant role. If you really ask me, 2 important modalities which is going to play a significant role in echocardiography, one is strain, whether it's LV, LA, RV, RA. And second modality is 3 dimensions echocardiography. So these are going to play a significant role, and they'll be very good because of their easily availability, cost effective, and reproducibility again.
If there is no question, thank you all the chairpersons like Dr. Satish, Govind, Dr. Johann, Dr. Prabhu, and also all the eminent speakers like Dr. Rakesh Gupta, Dr. Elizabeth, Dr. Sanjay Biswamitra, Dr. Sanjay Gami. I thank you.
Dr. Mahapatra, can I ask you a question before you leave, okay, before you ask us to leave?
Yeah, tell me.
What do you eat every day? Itni energy kahan se aati hai aapko? At the age of 60 plus,
yeah,
what do you eat? You tell us your diet, like we start eating the same thing.
Yeah, I am 65 plus.
Sir, don't reveal your secret, sir. Don't reveal your secret.
I don't take lunch. I take breakfast. Okay.
Thank you very much.
Thank you.
Thank you, Dr. Rakesh. Thank you.